field approach to treatment can be beneficial in patients with actinic keratoses. For Global Medical News Network, I'm Heidi Spleet, reporting from the Orlando Dermatology Aesthetic and Clinical Conference in Orlando, Florida.
Cryosurgery only treats the visible lesion. We now know, and the Europeans have known this for many years, that the entire field has a concept called field cancerization. And what that means is that you have mutated cells not only within the visible actinic keratoses, but even in the surrounding seemingly normal appearing skin. So although cryosurgery is very appropriate for treating isolated and discrete lesions, because most field treatments aren't effective where the lesions are thick and hyperkeratotic, we generally recommend that you sweep in at a later time, a week or two, and use a field-directed therapy, which will treat all of the mutated cells and bring subclinical lesions to the surface, so to speak, and destroy them. So this then helps them eliminate new lesions from developing at a later date and reduces the number of cryosurgical interventions one needs to do. So that's good for the patient. Photodynamic therapy is one of many of the treatment modalities that we have available to treat actinic keratoses, all of which are good, all of which have a role. PDT, when it was initially released and used on label, is a lesion targeted intervention. In other words, you put the agent that's going, the prodrug, on the individual lesions, let it incubate, and then you sweep in by using a light source that will be activated by the protoporphyrin 9, which is created by the prodrug. The problem is that most of us are now using PDT off-label in a field-directed modality, because that makes much more sense in trying to treat all the mutated cells that are even in the contiguous, seemingly normal appearing skin. So there are two agents that are now approved by the FDA for lesion-directed therapy. One is Levulan with the blue light. The other is Metvixia, which is used with the red light. The blue light is much more potent. It's a shorter wavelength. So it's much better, in my opinion, probably for treating actinic keratoses. The red light, which is used more in Europe, penetrates more deeply. And although very effective for actinic keratoses as well, it can also be used for basal cell carcinomas because the light penetrates more deeply. So they both have a role, but which one wins the battle as being the most efficacious for patients is yet to be determined.
What's next in the pipeline for AK treatment?
I think the next intervention we're going to see on behalf of our patients who suffer from actinic keratoses is a drug that's been known about for many years. It's a milkweed extract called MAL-PDT. And this is a drug that we don't know the exact mechanism of action, but you can put it on for 2 or 3 days and get a very robust reaction with very good efficacy. So this drug is currently undergoing clinical trials, and it is our hope that this is a drug that will be available for us in the near future to have another agent in our armamentarium to treat actinic keratoses.